your kilt on, because we've got one cardiomyopathy left to discuss, and that's hypertrophic cardiomyopathy, abbreviated HCM or HOCM. HCM is a condition where the heart muscle in the septum grows or hypertrophies. Remember, this is not the same kind of hypertrophy we saw in heart failure, which occurred as a response to pressure overload. Instead, a genetic defect causes isolated septal hypertrophy, and the septum can get pretty massive, causing some severe outflow obstruction as blood tends to leave the left ventricle into the aorta. It's like air trying to make its way out of a set of bagpipes. It's obstructed, and you just gotta... that's better. And these aren't just any bagpipes. I'm talking the Great Highland bagpipe, friends. You know the one. There are 3 drones and like a chanter or something. I think you put your mouth on the sporin, maybe? Oh, wait, no. That's the dangly man cursing in the front. Silly Ricky. Well, obviously it's complicated, so let's go through it step by step. All right. Hypertrophic cardiomyopathy involves myocardial hypertrophy. Just take a look at the size of that bagpipe. Bag, I guess it's called. Unlike a heart suffering from dilated cardiomyopathy, which turns all flabby and poorly contractile, HCM hearts are thick-walled and hypercontractile. No systolic dysfunction here. There's just no stopping that P-broch. It's actually the intraventricular septum that shows the most significant amount of myocardial hypertrophy, hence the highly accentuated septum in the center of that tartan design. In about a third of patients, the septum is so massive that it comes into contact with the mitral valve and blocks blood from leaving the left ventricle. This outflow obstruction is depicted by that knot there, in that pipe. The brass drone, if I'm not mistaken. In most patients, however, this obstruction isn't too severe. The myocardium, however, does not like to relax when it's all hypertrophied like that. Also, the chamber size becomes markedly reduced. All in all, this means diastolic dysfunction. In other words, you're going to have a hard time filling that ventricle. And if you look at that Highland lady in the back there, you'll see that there are definitely some filling problems afoot. Diastolic heart failure, specifically, is embodied by that sad and failing heart balloon. Whenever you see that balloon, think of all the typical findings associated with heart failure: dyspnea, bivascular crackles, and peripheral edema, just to name a few. Although there are rarer sporadic forms that occur in the elderly, most cases of HCM are inherited, the result of a missense mutation in one of several genes that encodes sarcomere proteins. HCM exhibits an autosomal dominant inheritance pattern, with almost complete penetrance. At Sketchy, whenever we want to highlight dominant, just look for that autosomal dominant domino, this time incorporated into our hypertrophic bagpiper sporin. Compliments on the sporin, my good sir. There are 3 mutated proteins that are usually involved. The one that they just love to quiz students on is beta-myosin heavy chain. The other 2 are myosin-binding protein C and troponin T, all components of the sarcomere. Mutations in one of these 3 genes accounts for up to 80% of all cases of HCM. Beta-myosin heavy chain specifically is depicted by that myosin-esque chain, linking the 3 drones together. One thing to note here, although mutations in the gene encoding beta-myosin are also known to cause dilated cardiomyopathy, the effects of the mutations are opposite. Those that cause a gain of function and increased myofilament activity result in hypertrophic cardiomyopathy. Those that cause a loss of function and decreased contractility result in dilated cardiomyopathy. So we're dealing with increased myofilament activity here. On gross pathology, you should see massive septal hypertrophy and a narrow left ventricular chamber. Microscopically, you'll notice that the myofibers look all tangled, abnormally shaped, and disorganized. It's just like this disorganized tartan pattern on his kilt. You knew there was something a little askew there, huh? Aberrant myofibers means an aberrant conduction system, and this can lead to fatal arrhythmias and sudden death. Throughout this course, we'll talk about arrhythmias that originate in the atria or other supraventricular structures, like AFib, A-flutter, Wolff-Parkinson-White. It's the ventricular arrhythmias, however, that you need to watch out for. Ventricular tachycardia or fibrillation leads to 0 cardiac output and sudden cardiac death. See that quivering heart accordion on top of the latest victim of this year's Battle of the Bands? It's meant to evoke an image of fatal ventricular arrhythmia. Although HCM can present at any age, it typically manifests during the postpubertal growth spurt. In fact, HCM is the most common cause of sudden death in young athletes, and that's why, up top, we've drawn in a super sweaty athletic sweatband. In a question stem, or in the real world, when you read or hear about a young athlete who dies suddenly, HCM should be among the first things that come to mind. So the major clinical problems we're dealing with here are diastolic heart failure from hypertrophy, sudden cardiac death from abnormal conduction, and on top of that, we've got obstruction issues, remember? Obstruction to blood flow from the left ventricle to the aorta, if present, is below the aortic valve. That's why we've given the very top of the drone that characteristic tri-leaflet aortic valve shape. The obstruction is happening somewhere underneath. It's actually the mitral valve that comes into play here. Let me show you what I mean. On echocardiography, you'll see what's called systolic anterior motion of the mitral valve. So when our hypertrophic Highlander contracts, he sends that mitral gesture, complete with bicuspid hat, tumbling anteriorly. Come on, it's bagpiping 101. Never step in front of the chanter while someone's in the middle of rocking that P-broch. As blood tries to exit the left ventricle, the anterior leaflet of the mitral valve, bam, slams up against that asymmetrically hypertrophied ventricular septum, and now flow into the aorta is obstructed. Once that leaflet is displaced, the mitral valve opens up, allowing blood to flow backwards into the left atrium. See how his beverage is sent flying upwards, regurgitating through that floppy, dilated bicuspid hat? That's mitral valve regurgitation, a common finding in patients with HCM. That in itself can cause a systolic murmur, hence our recurring systolic spray. The murmur we'll be focusing on, however, is the murmur caused by outflow obstruction, as blood tries to sneak past that enlarged septum and out to the aorta. You should hear a harsh crescendo decrescendo in between S1 and S2. And because it's a systolic murmur, we just had to include that sketchy systolic spray. You'll hear it best at the left sternal border or at the apex, without radiation. One of the most highly tested topics with respect to HCM is understanding how the severity of the obstruction, and therefore the intensity of the murmur, can be modified by external maneuvers. We tried to incorporate all the maneuvers that increase murmur intensity right here, underneath that harsh yet undeniably comforting murmur emanating from the bagpipes. First, notice his face as he strains during the last few notes of that epic croon lua. Valsalva maneuver decreases venous return, and thus volume that reaches the ventricle. That means less preload, a smaller chamber, and an even tighter space for blood to squeeze through. More obstruction means a louder murmur. How else can we decrease preload? How about standing from a seated position? Blood pools in those knee-high Celtic socks, venous return decreases, and preload decreases. A smaller chamber means more obstruction and a louder murmur. Drugs that decrease preload in a similar fashion will also exacerbate the murmur. We'll sketch these agents on the left later on in the sketch, when we highlight the drugs that should be avoided in the setting of HCM. Alright, now let's try decreasing the intensity of the murmur. Instead of decreasing venous return like before, let's increase venous return. One way is with a leg lift. Blood is sent back to the heart, preload increases, chamber size increases, and now there's more room for blood to get out of that left ventricle. Less obstruction means a quieter murmur. See? Only a tiny hum. Squatting also helps move more blood back to the heart, increasing preload and decreasing the murmur. That's why he's in that weird, kind of half-crouched position. Don't worry, he's got a small pair of cut-off jean shorts under there. Still awkward, though. Increased chamber size from increased preload is key here. So we've drawn in this Celtic dude who's had enough of his friend's flashy style. Our recurring theme for increased preload is someone pulling on a load. Preload is what sits in the chamber. More room means less obstruction. Alright, let's see here. How else can we decrease murmur intensity? I know. Instead of increasing preload, let's increase afterload. Recall that the murmur occurs when blood squeezes through the obstruction and out to the aorta. If we increase afterload or pressure in the aorta, then the blood is forced to slow down as it exits the left ventricle. Decreased flow across the obstruction means a quieter murmur. So how can we increase afterload? At Sketchy, afterload is embodied by someone pushing against a load, like these two wrestling Scotsmen here, who thought Battle of the Bands meant, well, just a full contact battle, I guess. Afterload is increased by squatting, as well as sustained hand grip. Hand grip increases afterload by increasing the total peripheral resistance. Again, this results in a quieter murmur because of less overall flow through the outflow tract obstruction. Just one more thing to add to that murmur, by the way, and that's an S4 heart sound. It occurs right after S1 and S2, and it's caused by all that blood hitting the stiff, non-compliant ventricular septum. All hypertrophied and annoying. Whenever we emphasize S4, we'll bring back our stiff-walled S4 chair. All right, it's time to sketch in a few important clinical events that arise with all this obstruction going around. We've already covered why hypertrophic hearts are more prone to lethal arrhythmias, but it's important to remember that patients can also experience exercise-induced angina or syncope. To represent the pain and pressure of angina, we've brought back our heavy angina anvil. And syncope? Watch out for that sinkhole. What happened here? This bagpiping event really escalated violently. Well, the tachycardia that occurs during exercise reduces the fraction of the cardiac cycle spent in diastole. And yet again, reduced filling means the outflow tract is even narrower than normal. Stroke volume acutely diminishes, leading to reduced coronary flow as well as reduced blood flow to the brain. Not only that, the coronaries have a hard time getting all the way into that hypertrophied wall. That has ischemia written all over it. All right, let's wrap up this sketch with a brief overview of the treatment options for HCM. In general, treatment of HCM involves lifestyle interventions, such as avoiding strenuous exercise. Beta blockers are the mainstay of pharmacologic therapy. At Sketchy, beta agonists are symbolized by a rousing beta bugle. A beta blocker, then, is muted, just like a one held by our next Highlander, on the stage in the back. How do beta blockers help? First of all, they act as negative inotropes, and that means decreased cardiac contractility, as depicted by the floppy, relaxed strings on that base. This decreases the ejection acceleration. The theme we're kind of developing here is that slowing down blood flow across that obstruction is a good thing. Decreasing the pressure gradient actually allows more blood to get out of the left ventricle before the mitral valve flops over and blocks the outflow tract too much. Non-dihydropyridine calcium channel blockers can also be used. Non-dairy should remind you of non-dihydropyridine. And that calcium ice cream nozzle can only mean one thing: a blocked calcium channel. See how floppy that handle is? Calcium channel blockers also serve as negative inotropes, reducing contractility, decreasing that pressure gradient we've been talking about, allowing more blood to get past that obstruction. Both beta blockers and non-dihydropyridine calcium channel blockers act on the SA node as well to reduce heart rate. And that means increased time for diastole. Prolonged diastole allows for increased filling. See how we've emphasized increased preload here, as those rabid fans pull that Scottish soloist from the stage? Remember, a larger chamber means less obstruction. Another important preventative technique is placement of an implantable cardioverter defibrillator to prevent death from VTAC or VFib. Reduction of the septal obstruction itself can either be done with ablation or surgical septoplasty. And now, a few drugs to avoid. Each is going to increase obstruction in one way or another, leading to increased risk of angina and syncope. Overall, watch out for vasodilators. Let's start with dihydropyridine calcium channel blockers. Unlike their non-dihydropyridine counterpart, these agents like to vasodilate. See the size of that dilated nozzle? Peripheral vasodilation decreases blood pressure, which causes a paradoxical increase in left ventricular outflow obstruction. It's probably because less pressure in the aorta means less afterload. Blood is allowed to accelerate faster across that obstruction, and the outflow tract actually collapses sooner. So reduced arteriolar pressure and afterload can be a bad thing. As always, we depict peripheral arteriolar dilation with a pair of floppy, dilated arteriolar sleeves. Venodilation, it turns out, can also make things worse. Underneath her billowy and dilated venous skirt, we've brought back a recurring symbol for nitroglycerin, a box of nitro dynamite sticks. Nitro works mainly through venodilation, which decreases venous return and preload. Decreased preload means a smaller chamber and greater obstruction. I see some syncope in her future. Ooh, ACE inhibitors. Now there's a good one. I knew that Jester had something up his sleeve. ACE inhibitors reduce angiotensin II activity, thus promoting systemic vasodilation. And, as we described with those vasodilating calcium channel blockers, decreased pressure and afterload is not a good thing. Decreased angiotensin II activity also means you're going to have decreased production of aldosterone, and thus less volume retention. At Sketchy, a wet crotch can only mean one thing: some free-flowing diuresis. Less volume means less preload sitting in the chamber, and that's a great way to increase that ventricular outflow tract obstruction. All right, one last thing. HCM is one of the several findings in patients with Friedreich ataxia, an autosomal recessive trinucleotide repeat disorder. We'll get into the specifics of Friedreich ataxia in a separate video. For now, when you hear Friedreich's, just think of these free drinks. And ataxia? Well, at Sketchy, that usually means something unbalanced and toppling over, hence the unbalanced pyramid of pint glasses. This disease manifests in 5 to 15-year-olds and involves difficulty walking. The most common cause of death in patients with Friedreich's ataxia is, you guessed it, hypertrophic cardiomyopathy. All right, let's sum up this hypertrophic Highland bagfest into a few key points. Hypertrophic cardiomyopathy is hypertrophic because of an autosomal dominant mutation in that beta-myosin heavy chain, just like the one holding those drones together. As we illustrated on the front of our bagpipers, bag, I guess. This hypertrophy is mostly in the intraventricular septum. And this leads to 3 important clinical consequences. 1, you're going to get some obstruction. The mitral valve shifts anteriorly, blood can't get out, and you can hear that characteristic systolic murmur. 2, you're going to see some diastolic dysfunction because that big bulky ventricle doesn't want to fill. That means heart failure. And 3, just take a look at that disorganized myocardial tartan. Disorganized myocytes means disorganized conduction, which can lead to fatal ventricular arrhythmias and sudden cardiac death. To increase that systolic murmur, decrease preload. Just follow that guy in the center. In other words, stand up and valsalva to that sweet, sweet tune of Scotland the Brave. To decrease the murmur, tell your patient to squat or perform a hand grip maneuver. And if he's feeling extra free-spirited, a leg lift. Underwear optional, apparently. HCM is treated with beta blockers and non-dihydropyridine calcium channel blockers. Both of these slow down the heart, allowing increased preload and decreased obstruction. Remember, slowing down blood flow across that obstruction is a good thing. Just keep it low and slow. Avoid drugs that vasodilate. That includes dihydropyridine calcium channel blockers, nitro, and ACE inhibitors. The last thing you want to do is push your patient into that syncope sinkhole. And lastly, whoa, watch the blowpipe, buddy. Oh, you want to wrestle?